Welcome. My name is Jessica Nicaran, and I support transitions of care programming at the Child Neurology Foundation. This program is part of our ongoing series on emerging issues that children and families with neurologic conditions are experiencing as a result of COVID-19. These sessions bring together experts to have a candid conversation with the broader child neurology community. Today, we are with Dr. Ann Tilton, a pediatric neuromuscular specialist, and Dr. Christine Baca, who is an adult epileptologist. They will be discussing transitions from pediatric to adult care during the pandemic. We feel lucky to have both an adult and a pediatric neurologist today so that we can see both ends of the transition process. Dr. Tilton, can you please introduce yourself?
Oh, hello, I'm Ann Tilton. I'm a professor of neurology and pediatrics at LSU Health Sciences Center in New Orleans. I'm also have had the privilege of being the president of the Child Neurology Foundation, and I'm currently vice president of the American Academy of Neurology. The other thing I've really enjoyed doing and working with Jessica and with Christine is that I'm work on what's called TPAC, which is our committee within the Child Neurology Foundation that really is focusing and advancing, we hope, transition for patients from the pediatric age group through the course, as we say, across the lifespan into the adult care. And so I've been able to do all of those things in conjunction with the Child Neurology Foundation.
Great, thanks so much for being here. And Dr. Baca, do you mind introducing yourself?
Sure, thank you for having me. I'm Christine Baca. I'm an associate professor of neurology at the University of Colorado. And I am an epileptologist, meaning I'm a specialist in epilepsy, so I see adult patients who have epilepsy. And I also have a background in health services and have an interest in how we transition patients from the pediatric to the adult world and how they access care and how we coordinate care. And I've done some research in that area and have been thrilled to be part of this process. Thank you.
Great. At this point, Dr. Baca and Dr. Tilton will have a conversation about transition of care. We're looking forward to hearing it. Thanks.
I will start out the conversation because as we think about it, it's something that begins earlier in life in the pediatric age group, at least. Now, I laugh and say my pediatric age group, I saw someone in their 30s the other day. So it is a continuum of life. But what we accept when we talk about transition, which just isn't transfer, but transition, is that it is a process that begins early and one that people can anticipate and has significant steps along the way in order for there to be a very seamless kind of change from the pediatric care into adult care where the rest of their hospital needs and medical needs really can be met. So I think part of the issue that we're dealing with today is the fact that during a time of pandemic and during the difficulties of this, that a process that's often seen as difficult anyway becomes more problematic. And it can become problematic in a lot of different ways. And part of that is just because we're virtual, we're doing telemedicine and we're not actually seeing the patients, and that patients are reluctant to come to the hospital to be involved in medical care where they think there might not be safety. And often those children that need the most levels of transition and medical care are those who are probably the most vulnerable for transition anyway. So I think that that's probably why we're sitting here today talking about some of the difficulties that we're really having. We can talk a little bit more about it in detail, but maybe Christine, can you talk a little bit about how it is from the adult side?
Yeah, I was actually wondering, Dr. Tilton, though, before we maybe get into the adult side, maybe what you think about some of the particular problems that you may see or concerns you have about transitioning a patient and transferring them right now. Well, you mentioned vulnerable patients, and I'm just wondering kind of what your thoughts are when you're seeing a patient about, you know what, we were thinking about transition and transferring, but I'm really concerned right now might not be the best time, and kind of what goes into your decision making about that and what you're experiencing on your end talking to families as well.
Okay. Well, thank you. I think it's multi-leveled. I think that the families just in terms of functioning and everything are stressed terribly right now. And they are dealing with a lot of uncertainty and a lot of difficulties in whether it be their workplace, home, school. I mean, everything is just sort of topsy-turvy right now. So transition to a new physician, new location potentially, new everything is one more difficulty that one adds on to that. So just from a family support and family standpoint, even if someone was almost on their way, in fact, I got a phone call from a patient's family within the week saying, I just can't do that right now. I just, can you please just hang on to me? And of course, because good transition means you don't just say, bye, last tag and let someone go. Instead, you say, once you're settled, let me know. And this just isn't a good time. So secondly, I would think, and you can speak to this yourself, but from a receiving standpoint, people are really trying to maintain and take care of patients and take care of high acuity. And to add one more thing for that physician to accept and to do when there's this amount of change and upheaval probably isn't the best time for them either, to really give that person the time and do the steps, which maybe virtual is really going to help. But I think from that standpoint, it's also going to be difficult. And they're going to need medication. We don't know if this is going to be 2 months or 15 months. And so, but what if I run out of medicines? What if I don't, so I think continuing with where we are, keeping the playing field kind of as level as we can in a time of upheaval is something that I think about, and try not to add one more disruption into what's going on. Now, with that said, it doesn't mean the clock stops, because these people are turning 18, are turning 21. And with that, legal things still continue. They need to have all of that done, even though the courthouses are locked down. They need, if they get sick, now if they've had probably a long-standing relationship with any facility, hopefully they would take them in, we would. But let's say they have a new appendicitis or they have a new other thing, then it is quite possible that they do need adult care or something else, and they don't have that transition in place. And that's more of an issue as well. So I guess from my standpoint too, since I feel very close to these patients, and particularly ones with difficulties, then I'm not pushing it. I'm saying let's put the brakes on. We're going to put it in neutral, and then not abandon what we think is best care, but instead kind of keep it going. That's probably true. I mentioned the child who has multiple needs. It's probably also true for just someone transitioning who has well-controlled epilepsy or well-controlled something else, because they often are lost anyway. What we know in the renal transplant group and the heart, congenital hearts and all of those, is that very quickly a scheduled appointment could be missed, and then how do you reschedule it and all of those things. Plus they may have their own illnesses and other things going on. So it's a time, even in the best of circumstances, I think, where there's some disruption. And when you already have the kind of disruption that we have right now, from financial to emotional to on and on, then I have to admit, I kind of take my time. And if someone's ready to go and they've got it set up, by all means. But I think that's going to be the minority.
Yeah. Yeah, I agree with you on so many levels here. So as the adult doctor in this process, and I'm the one usually receiving people, through a quote transfer after what you would hope is a nice transition preparation, but sometimes isn't always. We do our best, but sometimes things happen where people are not as prepared as they could be in that process. I couldn't agree with you more that during a time of disruption, I think we aim for stability, and we aim for medical stability, social stability, psychological stability, and that applies to the patient and that applies to the family. But to that end, I would say, there have been some surprises for me, and they've been a little bit of serendipitous surprises. And I think you've hit on the topic that I think I'd like to dive into a little bit more, and that is telehealth in this process. So obviously, many of us are seeing patients via telehealth and virtually, and many patients are being seen that way. And while maybe it wasn't designed as a way to, purposely see people through this transition period, sometimes it's just happened that way. And I've seen patients, they've been put on my schedule, and all of a sudden here we are having this appointment. And I think a couple of things I've learned that have been very surprising and make me a little bit more optimistic about this during this time period that's pretty disruptive, admittedly. And that was that there was a couple patients in particular where the patients themselves had pretty severe developmental or intellectual disability and were not functionally independent. And they really relied on their parents to help them with all the transition and the transfer. And in fact, once we started the appointment and I was talking with the parents and meeting them, it became clear that not having to go to the clinic was actually very important to them. And I don't think they realized that before we had the appointment. But meeting me in that way, in kind of the safe space of their home, where they didn't have to drive somewhere, they didn't have to transfer their young adult child, from the parking lot to the clinic. They didn't have to sit in kind of what most people think of as kind of a sterile, cold adult waiting room. All of those things were no longer present. And we had some space and time to really talk, and I got to see them in their own environment, which for some people really works and for some people really doesn't work. So I think we're still learning as we go. But for these particular patients, it actually worked in a very surprising way. I think we were both surprised that, this actually may be a way to move forward, even independent of a pandemic, because transfers to the clinic in terms of getting there are just a lot of stress for the patient and therefore the family. And a lot of what I do when I first meet a patient is really kind of get to know their story, their history, start to develop a relationship. It's a lot of talking. Which we can do virtually. And admittedly, I do miss seeing patients in clinic, immensely. I miss, the role of being near humans and touching people and whatnot. But I do think that this may be an opportunity that for some people may almost be like a beginning into the transfer process, almost like we're opening the door just a little bit, welcoming you in, and we're going to take small steps. And I pose that a little bit based on a very small experience so far, but I'm putting it out there as food for thought for everybody, not, for providers and for patients and families. I think we're living in a time of uncertainty, and that is really, really hard. And it's uncertainty with respect to timeline. And as time goes on longer and we maybe have to adjust our ways, maybe this is something that we're going to have to modify a little bit more if this goes longer. And I guess the message that I feel good about is that I think we can do it. And I'm optimistic that we can still take care of people, as they need to be cared for in different ways. When patients are, have a lot of urgent medical needs, I do agree if we can keep them with that provider that they've known for years, that is ultimately better. But I do think if this goes on longer, we will develop strategies to kind of communicate better in a virtual way and still make sure patients are getting the care they need, and perhaps open their eyes to some new ways of being seen that may actually be good for them in some ways. It may actually work for them, may not. But the other thing I was encountered that actually was a difficulty with telemedicine that I wasn't sure if this has come up for you, was some patients I have that I see in my local area here are college students. And in the setting of the pandemic, they've gone home and they may not be in Colorado anymore. And telehealth has posed some barriers with seeing patients out of state. And so I'm wondering if you've had any experience with that and any ideas in terms of how we manage and take care of those patients.
Well, lots of interesting things to respond to there. One is I would love to sort of echo what you said about the child with disability, about how much better this is in a lot of ways. I remember on more than one occasion going out of my clinic downstairs and seeing the patient in their car, because they really were much having, the family was thrilled. But I mean, I did a house call in a car. I went down there and they just sat in their chair and I did my thing, you know, and I think we all miss our knee hammers and all of that. But I really do. I'm just, you know, and eyes, I mean, it's so strange. But so I think that this is going to be helpful. And I laugh when every time I get on one of my telehealth conferences now, I go, well, what did you think of the parking? And they're all like, oh, it's the best, because we have notoriously had
Oh,
that.
yes.
You know, got a parking lot, it was full that day, you know, just boom. So anyway, and they all go, oh, wow. So I think the convenience, the set of people who are much more comfortable in their own home, the cost related to all of that, for those people is going to be very helpful. You are, however, intruding in their home, which is, you know, kind of a new social kind of thing for us. I mean, we haven't, you learn sometimes because you're like, oh, I can see them when they're really playing in their own room. But by the same token, we're in their home, you know, and that's sort of a private area, and we've been invited in, which is quite a privilege, to be honest with you, that they've allowed us into their homes. So that's, I guess, one of the things that I think is really helpful. The other, before we even launch into the part of the negatives, is that when we were working on doing transition here, our hospital for pediatrics is physically freestanding and away from where the adult people are. One of them, I don't know if you have this in Colorado, but they call it, they're on the West Bank. And it is, if it's not high traffic, it's faster to get there than almost any place, but it is a geographic barrier. It's like the craziest thing, the bridge, you know? And so part of our transition to adult is on the other side of the bridge. And it's hard to, I mean, if the world were perfect and we were doing transition, you and I would be in the same room, meeting the people if we were in the same city, meeting them, introducing, they trust, let's say as a pediatric, they trust me, I trust you. Therefore, that barrier of that hopefully is alleviated. And they get to meet you, they get to know you, and they feel good. And so we were desperate to figure out how to do this, and always said, you know, virtual health might be a chance. And suddenly we're, boom, in the middle of it. And I really think it's going to be something. I think because you're in Colorado, I could have my patient here with the family. Say, I'd like you to meet. You could talk to them. And I could say, I've worked with her. I trust what she says. She knows what I've told about, because even when we transfer patients, we keep them exactly the same. Then we work on changing things. So I think that there's a new layer of trust for that. So there's the convenience, the child with special needs, and the fact that it'll be a very nice way, without the burden of travel across those barriers, to have people feel like they're connected. So then when they go across, they meet you, or the other way around, you know, then they go, oh yeah, I recognize you. And you're much more, you know, much more familiar. And so I think those things are other aspects of good things. But we are a cognitive specialty, so I think that it does fit. And I'm curious about, did y'all transition very quickly over to telemedicine in your practices when this pandemic hit? We were full virtual.
It felt like we went from 0 to 6.
We were full in 1 week.
Yeah. I mean, I know institutionally we were, doing less than 100 visits a day. This is the whole institution, so not only neurology, but just to give you a sense of magnitude. And we're now doing over 4,000 a day. So it's immense. It's immense, and it was basically over the course of a week and a half. Things just became all telehealth, and I think, you know. Obviously, we're doing this in the interest of keeping everybody safe. And I think, though, that there's going to be some things that we learn through this process that may have some particular relevance to how we transition people and do transfers in the future, that we will take forward even as we move beyond the pandemic, whenever that will be. And I really like what I heard about, communication. Communication between the pediatric side and the adult side is so key, and also kind of demonstrating that communication to the families, in front of them, that we're a team. And I think that's really important. And I think telehealth could actually create an opportunity for that would be more feasible than, doing something in person sometimes, given the quote geographic barriers that you named. Although I find it funny because we are actually here in Colorado, we are technically on the same campus, but you would think that there was a wall in between us sometimes.
Yes.
Right. And, you have to walk all the way across. So it sometimes feels like a different world, and it feels like you're very far apart. And you would have to park in a different parking lot if you're the patient. So, it's different. It's different. But if we could connect, even for a short time, with two providers virtually going forward, that I think would really help this process. And it's a model that we've all been talking about for a long time and trying to figure out how best to implement it. But maybe there's a new way to implement it that this experience is shedding some light on. And I also agree with your observation that, the telehealth can be a window into kind of their lives that may be beneficial in kind of watching them in their own environment and kind of observing them without kind of the sterile or kind of, maybe not as natural environment as the doctor's office, but at the same time, it is their home, it is their private space, and we want to respect that. And I think these are the things that we're going to be, we need to think about more. And we also need some, feedback from families about what this really means to them, so that we can make sure that we're kind of, adhering to their values and but also ensuring that we give them the best possible care. So I think all of these things are important, and all of these things are on our minds. It's just beginning.
Uncharted in a lot of ways, like
It is. It
a
is.
lot of things right now. But I think it's going to be the future. I really do. And I know in our practice it's going to be the future. I think I really get feedback that patients and parents really like it a lot. And now we all are going to have to decide how we best implement it in terms of new patients follow-ups, both through and kind of change the way. And maybe because of the way this spun very quickly of procedures out, the cognitive specialties like this, the importance of what we're doing here, really kind of all of a sudden moved up in terms of how administrators said, wow, look at all this work that's going on and these rapid, being nimble. That's the magic word now. You have to be nimble so that you can, in 1 week, go from 100 to 4,000, or a week and a half when you think about that. And also just where the internet has allowed us to go, or FaceTime, or even by phone, something. And this is one of the things you brought up, and that was about crossing state lines. Mm-hmm. Turns out one of the patients I need to do goes to Texas, and I have a Texas license. It was like, what are the odds? But that is a problem. So on the level governmentally, with our advocates, say through the American Academy of Neurology, through some of those others, they're going to have to really say telehealth is here and it has importance and it has weight. They're going to have to say, do we also say phone? And they're going to have to say these somewhat artificial lines are open, but there's implications of that as well. I'm in Minnesota and I say, I'll see everybody all over the world or all over the country. That also has to be regulated. And so I don't know if you have to get licenses or you have to, I think they need to know who's practicing in their state and what they're doing. So that, I think, the devil's in the details, and it's going to be following.
Yeah, no, I totally agree with you. I saw a patient, I'm in Colorado, obviously, and I saw a patient last week in Wyoming who was a known patient of mine, and I was able to do that given some new policy changes. However, this morning I couldn't set up a way to see a patient who's in Nebraska because policy changes were not advantageous to doing that, and if anything, just totally put a barrier there. So But I hear you. What does this mean as we kind of, quote, break down barriers, yet also we don't want complete chaos in the process.
No, because we aren't centralized.
Yeah, exactly. And I think we're really, as a field, going to have to think about what this means going forward. I mean, so much has changed so quickly. It makes me optimistic that we can change policy going forward and learn from what we've done already and continue to provide all our patients the care they need, but also react to the things that aren't working. We really we do rely on our patients and our families to tell us this and inform us what's working for them.
And I think we will probably be reaching out and asking those things, because now we're going to be gathering enough information. But I think we're going to turn it back over to Jessica, who has been a remarkable moderator. She just sent us down the path. And so this has been just wonderful speaking to you. Thank you so much.
Yes, thank you, Dr. Tilton.
That was fantastic. Thank you so much to both Dr. Tilton and Dr. Baca for being with us today and for sharing their expertise with us. That's going to wrap up today's conversation, but of course, this is a conversation that we need to continue having. So for more resources about transitions of care related to the pandemic and COVID-19 generally, you can visit our resource center at childneurologyfoundation.org/COVID-19. And remember, together we will get through this, and together we are all child neurology.